Patients with autoimmune diseases will often have multiple autoimmune diseases at the same time, and one of the very classic pairings in patients with rheumatoid arthritis is Sjogren syndrome. Classically, there's a triad of 3 symptoms that are seen. Number 1 is xerophthalmia, which refers to dry eyes but may present with patients saying that they have the sensation of sand in their eyes, namely because they are not producing tears effectively. Number 2 is xerostomia, which means they have the sensation of a dry mouth, which can also cause dysphagia, namely because chewed food is not being lubricated with enough saliva to make it easy to swallow. Number 3 is arthritis. Patients with Sjogren syndrome may also present with parotid enlargement, which occurs because it is only the submandibular and submaxillary salivary glands that stop producing saliva, while the parotids have to make up the difference. They then compensate by enlarging. Patients with Sjogren's may also have an increased risk of B-cell lymphomas, which are more likely in patients with autoimmune diseases as a result of chronic inflammation that predisposes dysplastic changes. Finally, patients with Sjogren's are also more likely to have dental caries, likely because saliva has a number of chemicals that will aid in dental health, but without these enzymes, teeth are more likely to have bacteria and plaque is more likely to build up. The antibodies to know for Sjogren's disease are anti-ribonucleoprotein antibodies, anti-SSA, also known as Rho, anti-SSB, also known as La, with Rho and La being the more important ones to remember. Sjogren's tends to affect females between 40 and 60 years of age, who often already have a history of rheumatoid arthritis. That said, you don't have to have rheumatoid arthritis to get Sjogren's. In fact, a related syndrome, Sika syndrome, presents with many of the same clinical features, just without the arthritis. They will have dry eyes, dry mouth, and dry nasal and vaginal cavities, as well as chronic bronchitis and reflux esophagitis. Just remember, as I said before, no arthritis. The next disease we'll discuss is gout, a relatively common disease that is important to know well. Biochemically, the disease is characterized by the precipitation of monosodium urate crystals into joints due to high serum uric acid levels. There are a lot of causes of gout, theoretically due to 2 major problems. Uric acid can either be overproduced or underexcreted, which can cause high serum levels, thereby leading to a higher likelihood of crystal deposition. Of the 2, underexcretion represents about 90% of cases. The causes include Lesch-Nyhan syndrome, PRPP excess, decreased excretion of uric acid, normally due to iatrogenic causes, increased cell turnover, which we'll talk about in a second, or von Goerk's disease. The case vignettes are always fairly similar, usually with some external insult leading to a gouty flare, likely in a single joint, most commonly the MTP of the great toe. A classic example is a patient who is treated with chemotherapeutic drugs for leukemia who turns over cells very quickly due to rapid cell death from the chemotherapy, leading to a huge overproduction of uric acid. This precipitates a gouty attack, thereby causing a man being treated with a standard therapy for his cancer to present to your clinic with joint pain. The way that oncologists have historically avoided this problem is by pre-medicating all patients with large tumor burdens with allopurinol, a blocker of uric acid production, to prevent it from being created and allowing serum levels to stay low. We'll discuss this more in the pharm section of the chapter. The symptoms of gout classically consist of an asymmetric joint distribution and often a red, swollen, painful joint, most commonly the MTP of the great toe. With long-standing gout, the crystals can precipitate into deposits called tophi or tophaceous gout. These tophi can be anywhere, but are classically found on the external ear, the olecranon bursa, or on the Achilles tendon. If a patient has these long-standing clinical signs, you should have a high suspicion for tophaceous gout. Remember, the tophi themselves don't cause the problems, it's actually the acute attacks that are painful, and they don't occur at the sites of tophi necessarily. These attacks are often precipitated by eating large meals or drinking alcohol, both of which allow for uric acid levels to increase. With alcoholism, as with HIV and certain other important chronic diseases, it's important to build a list of common complications and diseases that often present with them that you can use as a shortcut when you see them in a clinical vignette. This is a great one to add to the alcoholism folder in your brain, along with thiamine deficiency, B12 folate deficiency, and DTs. The treatments for this disease are varied and usually determined by the clinical presentation. In the acute period, a patient is coming in because they have a very painful joint. The goal here is not to try and acutely drop their serum uric acid level. The goal is to simply control their pain and inflammation, which is accomplished by NSAIDs, steroids, and sometimes colchicine. However, when the acute flare is resolved, the goal is actually to try to reduce serum uric acid levels and keep them low so patients are less predisposed to acute attacks. This is accomplished mainly by allopurinol, which inhibits the formation of uric acid, and less commonly probenecid, which causes the kidneys to excrete more uric acid. Before we move on to pseudogout, we should talk about one more aspect of making a diagnosis of gout that is very important. To make a definitive diagnosis, often you look at the crystals that precipitated into the joint space. They are described as needle-shaped and negatively birefringent, or yellow when parallel to polarized light. This comes up in a lot of questions, so it's worth memorizing, especially as it's the main way to distinguish between gout and pseudogout. Just remember that for gout, the words yellow and parallel both have double L's in them. Pseudogout is quite literally what it sounds like. It's just like gout, except it's different. The key distinction when you're trying to make the diagnosis is seen when you observe the crystals under microscopy. Rather than appearing as yellow when parallel to polarized light, like what happens in gout, in pseudogout they appear blue when parallel to polarized light, and yellow only when perpendicular to polarized light. The crystals are basophilic and rhomboid, and are weakly positively birefringent. The reason for the different properties under polarized light is that the crystals in gout are made of monosodium urate, as we discussed, and are made of calcium pyrophosphate in pseudogout. Just remember that P is for both pseudogout and for pyrophosphate. Another major difference is the joints that are affected. Rather than the MTP joint, patients classically feel pain in their knee, or sometimes shoulder. Patients usually are older and are equally split between males and females, while gout tends to affect mostly males. Also, as opposed to gout, there really isn't any treatment for pseudogout other than supportive care. Infectious arthritis is quite often an orthopedic emergency. Why? Because it's a raging infection that is restricted to a small space in a joint. Usually it presents in a single joint that may then move to another joint, often asymmetrically. It presents with 3 different possible problems: synovitis, tenosynovitis, and dermatitis. Synovitis generally occurs in the knee, while tenosynovitis usually occurs in the hand. There are classic organisms that cause septic arthritis, most importantly, Staph aureus and Streptococcus. However, there is one other classic boards question, usually a young adult who is sexually active, who has a history of STDs, who presents with red, hot, raging joint pain, which often represents septic arthritis caused by Neisseria gonorrhea. When you see the teenager and joint pain in a question, your brain should automatically go to this. While infectious arthritis often presents acutely, there are some examples when it occurs chronically. The 2 important ones are Lyme disease, where in the 3rd stage of the disease patients may present with arthritis, and also disseminated TB, which can spread to the joints. Osteonecrosis, or avascular necrosis, occurs when the blood supply to bone is interrupted. It often presents clinically as pain that occurs with activity and can be caused by a variety of etiologies, including trauma, high-dose steroids, alcoholism, and sickle cell disease. If the blood supply to the part of a bone involved in a joint is affected, it can often lead to destruction of the articular surface, causing significant joint pain. On X-ray, it generally presents with irregular, non-uniform patterns of lucency and opacity in the affected region, with possible joint changes if the articular surface is affected. Seronegative spondyloarthropathies, a long term for a somewhat straightforward set of diseases. Basically, these are a group of 4 inflammatory arthritides that affect the spine and are seronegative. That is to say, they have negative serologies for rheumatoid factor. Commonly, these diseases affect males. Among the more boards relevant facts in this section is that these diseases are associated with the HLA-B27 antigen, a gene that helps to encode for MHC1 molecules. Again, there are 4 types of seronegative spondyloarthropathies, including psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis, a list you can remember with the memory aid PAIR. Psoriatic arthritis is exactly what it sounds like, an arthritis that is strongly related to psoriasis, presents often with joint pain and stiffness. Around 1 in 3 patients with psoriasis will develop related arthritis. The reason to keep this disease in mind is that the clues on radiography are often giveaways. For example, pencil and cup deformity, as well as dactylitis or sausage fingers, are fairly pathognomonic for this disease. These are some of those buzzwords that should immediately take your brain to psoriatic arthritis. Ankylosing spondylitis is probably the most classic of all of the seronegative spondyloarthropathies. It is a disease characterized primarily by chronic inflammation in the spine, classically in the sacroiliac joints in the back, and then ascending up through the spine. As it ascends, it causes fusion of the spine, eventually leading to a complete loss of mobility. This ankylosis can be so severe that it may lead to a classic radiologic appearance known as bamboo spine, quite literally because vertebral bodies appear to square off and stack perfectly on top of one another. Additional symptoms include uveitis and aortic regurgitation. 2 important symptoms to know, as they can be common and should not dissuade you from considering the diagnosis of ankylosing spondylitis. The next arthritis discussed here is the one associated with IBD. There is no single differentiating symptom that you need to be aware of here, but expect that sacroiliitis that occurs in patients with pre-existing IBD is because of this seronegative spondyloarthropathy. The final type of arthritis here is reactive arthritis, which used to be called Reiter's syndrome. It is known for a classic triad of conjunctivitis, urethritis, and arthritis, which can be remembered with the memory aid can't see, can't pee, can't climb a tree. This is a great way to remember all the fully testable concepts. To consider this diagnosis, the vignette really should offer you a recent history of either a GI or a chlamydia infection, as these infections are what precipitate eventual reactive arthritis.